My name is Chris Starr. I am an associate professor of ophthalmology, a cornea ocular surface specialist at Weill Cornell Medicine in New York City. This project started actually over a decade ago with the original ASCRS preoperative OSD algorithm project, which we published in 2019 in JCRS. And we spent many years perfecting that and getting it to a place where we were comfortable publishing it and releasing it to the world. And it was great. And it was really well received. It was adopted worldwide, translated into many, many languages. I've lectured the world speaking about this, and I see the enthusiasm and of course, the need. Why do we need this? Well, of course, in the age of modern refractive cataract surgery, expectations are so enormously high. Patients expect perfection. And in order to deliver those results, you have to pay attention to the ocular surface. You have to optimize the ocular surface. You have to treat the ocular surface preoperatively. And then, of course, continue postoperatively. Educate patients preoperatively about the ramifications of undiagnosed and untreated ocular surface disease and the visual repercussions that those things can have, especially if one is implanting a premium IOL like an extended depth of focus or a multifocal IOL. Ocular surface disease of dry eye plus multifocal optics is a recipe for disaster in some cases, and you want to avoid disasters, and that's where this algorithm comes in. It's just a reminder is not the right word. It is a reminder for everybody. The more we talk about this, the more we present about it. ASCRS, Cornea Day in particular, and all the various journals like Ophthalmology Talks that mention it and allow us to talk about it, raises the awareness and the importance of this topic. And even though we created this algorithm to be it's pretty, not complicated, but it's involved. And there are steps and there are bubbles and decision trees and diagnostic tools. And it looks like a lot when you look at it on the paper. But what we're trying to do here is just remind people to just pay attention to the ocular surface, do whatever you do in your office to address ocular surface disease prior to cataract surgery, looking for all these little things. We tried to make it simple with little monikers like LLPP, look, lift, pull, push, which we introduced in 2019, and we have now refined it a little bit in 2026. We've added a few little nuggets in the algorithm to address consistency of astigmatism measurements and the keratometry measurements, which we didn't have in the initial version. This is just another sort of tool, another metric for assessing the quality of the preoperative measurements. If there's a lot of, we said within one diopter of the keratometry of the different men, and when we question the ASCRS Cornea Clinical Committee members, most people use 3 or more tools to assess biometry and the topography of the cornea. So that's a lot of data that all has to be processed at the pre-op exam. Some people use 4 or more. And so one of the things that we added to the algorithm as well is is there consistency amongst those 3 or 4 modalities within a 1 diopter of the average K and 10 degrees of the steep axis of the astigmatism. And that's generous. So a lot of people use a half a diopter or even a quarter of a diopter leeway between the devices and 5 degrees or less. But we added to the algorithm for the first time 1 diopter and 10 degrees as a reminder. Don't forget, there's osmolarity, there's MMP9, there's all these other tools, lactoferrin, non-invasive tear breakup time. Even we have a non-contact corneal anesthesiometer available to us now, which we didn't have in 2019. And that, of course, if you have that in your office, certainly plays a role in the sort of preoperative diagnosis of ocular surface disease. When I say ocular surface disease, we're talking all the dry eye and lumps and bumps and all that, but also neuropathic corneal pain and neurotrophic keratitis on the 2 extremes of the nerve disorders. And anesthesiometry of corneal sensation testing and the non-contact anesthesiometer, which I've been using in my practice, has been revolutionary in helping us pick up these traditionally kind of missed diagnoses and not addressed until kind of too late, neuropathic and neurotrophic. So we've added more language around that in this version of the algorithm. We in the 2019 version, we didn't have a FDA approved medication for Demodex blepharitis, which is very important to diagnose prior to surgery, because when there's Demodex, there's usually gram-positive bacteria, and it's the same ones that lead to endophthalmitis. And so you want to find that Demodex pre-surgery and treat it with, the FDA-approved medications for it and a whole bunch of treatments for it. But the important thing is identifying it. So in the look, lift, pull, push, we look at the patient, we look at the face, we look at the lids, we look at the blink, but we also have the patient look down. And looking down, you can see those collarettes much more easily. And if they're there, treat it preoperatively. We've also added a little bit more in the nerve realm. In the original version, we weren't clear about neuropathic pain and whether or not you proceed with surgery or not, or how it impacts the decision as to do surgery. And so this time around, we've made it very clear that if you diagnose neuropathic corneal pain, there is absolutely no elective refractive surgery. Don't do LASIK, PRK, smile, phakic IOL if the patient has corneal neuropathic pain. But in the case of cataract surgery, that's a medically needed procedure. They have an advanced cataracts. They need to have cataract surgery. And so even though it's technically what we would call a not visually significant or non-visually significant OSD, because the measurements are, tear film is good, the cornea is clear, those patients should be counseled that they have this condition, that it might get worse after cataract surgery, institute treatments, let them know that this is what they're dealing with. Because if you don't mention it prior to surgery, and it gets worse after surgery, well, that is viewed as a complication, and you're going to have problems on your hands. So it's always good to identify these things pre-surgically, discuss it with the patient, and treat it.